in non-classroom contexts in order to accomplish their goal-directed, valued goals in practical settings. And are we all set here? There's just like a lot of stuff going on. So I'm very interested in particular, as Andrew mentioned, which I'm not sure if you heard or not in the introduction, prior to coming to medical education, I did, depending on how you do the math, 10 to 12 years of work on training and educational development for the Army. And the nature of that work was to help understand how people develop job-related expertise on the job and how you coordinate formal classroom instruction with the practice-based instruction in order to have the optimum impact on learners. I've been interested in performance in high-stakes environments since I was a competitor, an equestrian competitor, and pretty much all the way forward from there. So what you'll hear in today's presentation, because of my orientation, will be very, very different than what you would hear from someone who's an educational psychologist or trained formally in education. Okay, I cannot advance the slides with the down arrow anymore. Okay, so I just click that. Yeah. Okay. So if I could get some group participation here, I would love to have your thoughts on a favorite learning experience that you can recall. What happened in that experience? What changed for you as a result? And how did that make you feel? Would anyone like to jump in with something fresh? Yes, go ahead and jump right in.
I remember the first time I got to see a real, true electron microscope, a transmitting electron microscope. Yes, I'm a geek, and I just had always thought that the images from these microscopes were amazing. And I remember my professor said, well, come on, I'll show you one. And he sat down, and I watched him so closely. And then he looked at me and said, would you like to try? And I said, yes. And I sat down, and I had watched him so closely that I was able to manipulate it. And he was just like, I can't believe you've already doing that. I said, I'm just so interested.
Fantastic. That's a great story. I can hear the enthusiasm still in your voice when you recount that story. That makes me want to go out and go check one out. Anyone else want to share something?
I would say anything that's experiential, like for me, is always something that sticks out. So, you know, more than just like a lecture or sitting there being told something, it's like being able to see it, do it, feel it, experience it. That's what sticks in my mind.
So like the opposite of what we're doing right now. To be fair.
Oh no, I'm waiting. I bet there's going to be some exciting moment come up. So.
Anyone else before we move on?
Not my learning experience, but when I hear about the PBL approach at the first time, it's really amazing for me. I saw that everybody is doing the lectures and learning by themselves, but I heard the opposite way. Give the case first and then let the students learn about it. Mm-hmm. So it was kind of stunning for me.
Yes, problem-based learning. I mean, we're kind of known for offering this kind of experiential learning opportunity for.
Yeah, we are so used to use it, but there are many people who don't know anything about that.
Yes, yeah. It takes work, I think, to continuously move a whole curriculum forward in that experiential way. Yeah. Okay. I think I'm similar in that I really love the experiences where we can have group conversations on tough questions usually they're like philosophical or ethical in nature. And I also absolutely love guided observations of experts doing things. Like it was something I've loved since I was doing the military work. To observe this expertise and start to unpack with someone who's got that expertise, who's kind of sitting next to me as an observer and learning about how they do things. And I love how these things prompt further exploration of my own ideas and beliefs and the way that the world works. And it makes me feel more efficacious to solve problems that I might have professionally or personally or whatever, because I have this sort of new way of thinking about the problems that I'm encountering. So as just a thought question for ourselves to think about, no one's favorite story involved the required HR training. So we might think about how not every form of instruction that we encounter or are made to encounter conforms to this expectation that we're going to have experiential learning that really matters to what it is that we're trying to do in our professional or personal environment. Although I know they're trying. Okay, so if you were to do a Google Scholar search on articles that topicalize adult learning theory, you're going to see the following characteristics as a summary, basically, of that literature. And so adult learning it's very much influenced by previous experience. We treat adults as not clean slates, that there's actually things you've learned, attitudes you've developed, beliefs you've developed, and baggage, of course, that you've developed as well, expectations and so forth from your previous experience that shape why you want to learn, what you want to learn, how you want to learn, and so forth. In general, this adult learning is thought to be self-motivated or intrinsic. So you're doing this learning because you want to and not because it's imposed upon you by someone else. And usually you're thought to want to do this kind of learning because it's instrumental to achieving your personally valued goals. So the learning is purposeful and instrumental for doing something in the world. And as we talked about in our previous little conversation, the adult learning is characterized by methods that are action-oriented. Again, because you're trying to develop knowledge and skill that's instrumental to something you're trying to accomplish. And so the work of learning tends to be interacting with those same environments and people and situations that you want to apply this learning to. So just to summarize, adult learning affords the learner agency and control in the environments in which they're operating. And they involve interaction with that environment and the people, the material that comprises that environment. And then finally, it involves involvement in the practical work that you are trying to accomplish by engaging in learning as an adult. And so we'll kind of explore these ideas in some of these slides. Okay. Now the question is adult learning really just for adults? So kids have limited previous experience, right, to build on, but the question is, do they really learn all that differently from adults? And I just want to highlight some of the characteristics of these pictures. I want to raise the question, for example, where are the toys, right? Kids love, when you search for pictures online of kids playing, you find them in the boxes, in the kitchen cabinets. How many of us do not have a picture of us as little kids in the Tupperware cabinet or with the pots and pans, right? Kids, they want to have from the earliest possible age that they can move about the world. They're seeking agency and control over their environment. This kid with the picture with the kid with the light switch, to me, is like a quintessential activity that kids engage in when they start to learn that their fingers do things and they can operate their fingers to change the world, right? And as soon as they figure that out, that light switch is toast because they're like, hang on. And they're like, agency is like a fundamental human drive, and it's operating at a very, very young age. There's a desire for interaction and involvement. Very interesting to me in these photos is that you see the two kids that are not absorbed in enacting their agency. Who are they looking at? They're looking at the camera, and they don't. And I'm going to guess they're pretty linguistic at this age, but they are very attuned to the other people in their environment and the degree to which these people are interacting with them. And then every one of these photos demonstrates their involvement in what the grown-ups are doing, what is happening in the world in which they're growing. And I feel like these photos really illustrate the need that we have to learn in this way from the very beginning. It's just that kids, they're kind of a captive audience, and we can sit them in classrooms and make them learn. But is that really the kind of learning that they're seeking? So just a thought question. So who are our adult learners? I just want to emphasize here that we're all learning all the time. But today's focus is going to be on students and postgraduate trainees, because that is our main area of focus with the medical school curriculum. So we'll proceed with that. So what does the literature have to say about what adult learning or clinical learning looks like? And the way that we are thinking now, the references in the lower right corner are somewhat dated, but the thinking along these lines has remained fairly consistent. That clinical learning is characterized by participation in clinical work. So participation in clinical work helps us understand whether learning has occurred, and it is through participation in clinical work that the learning happens. And in so doing, in participating in clinical work, that learner is moving from the periphery of their professional community toward the center. And what that looks like is the assumption of roles that are part of that community, autonomy to function in that community with one's own thoughts and decision-making capacities, use of the tools and language of that community, and identifying with that community. In this case, a professional identification with the professional community. And what this really looks like then is deepened participation in that clinical work, greater capacity to participate in that clinical work, accomplished by an intense involvement. So the workplace curriculum characterizes how we can structure the workplace. How we can structure the workplace so that we can promote this kind of intense involvement. And the tenets of the workplace curriculum, this theory of workplace curriculum, is that learning through work is a normal outcome of everyday thinking and acting at work. So the environment in which the work is happening is fostering this human development. But it's not a given that the workplace the workplace is going to foster the amount of learning that we might desire. And the fact is that factors comprising the social and physical environments and their activities and their interactions shape workplace learning and its efficacy. So, for example, policies for the degree to which various learners can be engaged in the clinical work will affect the degree of learning that comes out of that clinical work. That's just one example. And it gets complicated by things like having learners of very different levels all sharing the same workplace situation. And there's a need to enact clinical service and at the same time attend to the development of all these different levels of learners. So we have to think about the workplace and structure it in a way that facilitates learning from the work. So the experiences then afforded to learners and how they engage with them are central to the type and extent of knowledge that's learned through healthcare work. So if we're not affording, if we're not in a purposeful and systematic way affording various kinds of experiences to the learners, we are not necessarily optimizing our clinical workplace for learning. Okay, what's not in the workplace curriculum? Experts telling novices what they know, ideally in a controlled classroom setting. That's not characteristic of the workplace curriculum. That's not to say that there isn't a place for a controlled classroom setting or a place for more didactic education in general. It's that we have to understand how those forms of learning work in service to learning in the workplace. All right. So the question then is, how are we teaching our adult learners? I want to point out that when I looked for a picture of a kid playing with the light switch, I just did a Google image search. I could not find, I mean, that one picture was the only one I could find. There were hundreds of photos of light switch covers to prevent the kids from screwing around with the light switches. But there was nothing there, almost nothing there to actually show the kids playing. And when I looked up kids playing in the cabinets, cabinet locks, in fences, like it's really very interesting how we try to manage this sort of inconvenience of having this learner who wants agency and control and interaction in a context where we're busy, we have things that fall apart, you know, there's we come home from long work days and so forth. So there, you know, the reality is it's tricky to navigate these things. But the message that it's sending is telling kids to stop and keep out. So, you know, how do we navigate this? You know, this is a question for learners of all ages. So I'm going to put this now in a medical context and start out with these quotes here, which kind of were fascinating to me. This first one is from 1966, and I think it still applies today. Most teachers understand the importance of developing the student's capacity for critical thinking and self-education. But most of us are too busy telling them what we know to get around to showing them how we learn. It's probably even more true today as the clinical environment gets busier and busier and the time pressures get worse and worse. But the question is, what's the nature of this interaction with our teachers, with the artifacts in our workplace, with the other people that comprise that workplace? In the second quote, this fascinates me, in Hellenic Greece, so this is going back a ways now, anatomy classes and textbooks were introduced to medical education to compensate what? Hellenic Greece, what? A lack of student access to authentic medical experiences. What is going on here? Is this involvement? Like, what kind of involvement from a very historical period in time of developing physicians, what kind of involvement are we promoting? And then finally, in this literature review of work and service, teaching and service balance, the authors note that the literature we reviewed on balancing education with patient care delivery tended to privilege conceptualizations of education and service that understand them as separate activities. So you learn on the one side and then you practice on the other, and never the twain shall meet. And this I think is a source for the struggle between teaching and service balance, because if we're treating these as separate activities, our workload has doubled, right? So how can we think about how to bring these conceptualizations of education and service together by thinking about the workplace curriculum? And of course, this raises questions about agency. How do we promote agency among our learners if their education is separate from the clinical service that we're ideally teaching them to provide? So, what message is this sending? Basically, stop and keep out. So, all right, here's a depiction. I got a little fun with this of our clinical teaching system as I see it, through the lens of the workplace curriculum theory. We have at the center of our teaching system the attending physician. And then closest to the attending in this core of the professional community is the chief and the fellow and the chief resident. Then we have the more junior postgraduate trainees, a little bit further out in the periphery. And then a little further out, we've got the preliminary or transitional intern or the categorical intern, depending on your specialty. And then a little further out, we've got our med students out on the periphery. And then we have outside the asteroid belt here, or comprising the asteroid belt, is testing and documentation. So to get closer into that core, there is testing that has to be accomplished, and documentation, of course, of clinical service presents another sort of asteroid belt in terms of the agency that the learners can have in the workplace environment. We've got our allied health professionals kind of zooming through, kind of a wow, stop and look at that. Isn't that interesting kind of experience? And then not sure if it's still a planet. Yes, no, depends on your perspective. We have the patient. And so the question is, what does this system assume about teaching? Would anyone like to offer up ideas about that? I can take that away there so it's easier to see. What kind of message are we sending about teaching if our teaching system is organized in this way?
Looks like there's quite a bit of distance between the attending and the people on the outside, the students, whatever. Looks like they are not going to be able to learn as much if you're looking at physical distance there.
Mm-hmm. Right, physical distance from the attending presumably determines the amount of learning that happens from that attending. And the attending, if they want to teach, has to cross that distance to get to those learners. What else that you notice about that? Well, the interest.
Yeah, the patient will be the main teacher.
Yes.
The patient will be at the center of that orbit, and all the people taking care of the patient are also kind of learning as they go along, and so they would all, including the attending, with the attending being closest to the patient, of course, but that they would all be around the patient.
Yes.
So
Yes.
that's what I thought.
That's what we want. That's what we want. Yes. But the way that education in the workplace often tends to happen, giving rise to this sort of stress of balancing teaching and service, is that the patient is something to watch for, but foreign to the system. And the work of the allied health professionals is separate and kind of out of the way. But in fact, we are learning together. We are organized around care for this patient. And that fully anticipates the slide that I have a few slides down in this presentation. But this is often what ends up happening because we're pressured for time. And there's pressure against thinking creatively about how we can use the affordances of the workplace environment and the services of classroom and distance learning and simulation and so forth to help us accomplish service goals in the workplace environment. So we'll just explore that a little bit here. Okay. So the question is, how could we be teaching our adult learners? I have to say this picture on the left made me so happy because this is basically assistive technology for this kid that wants to use the light switch. It's an older kid, so maybe they're not using it as often as the toddler we saw in the very beginning. But my goodness, the agency and control that thinking through, what the learner's capacities are and what the affordances are of the environment and how to bridge those things so that the learner has capacity. I love that picture. And then these others, I think, illustrate the degree to which we can have interaction and promote involvement among our learners. So so in the picture with the boxes, I feel like this illustrates the way in which we can scaffold access to the kind of work that we're doing. So we're engaged with that learner, again, in the capacity that they can participate. This may be a little bit outside what this mother here or caregiver here is wanting to accomplish with all those boxes. They're not getting packed, for example. But it is, again, demonstrating thought with respect to what is it that learner needs from the interaction and how can this be provided in a way that uses the artifacts that are in the environment. And then involvement. I feel like this photo illustrates finding safe and engaging ways to learn together. It might involve simplified tools, for example. In this case, a simplified recipe. But identifying, well, what are the tasks that my young learner or my new learner can do effectively, and I can afford them the opportunities to engage in this work. And what are the things that I need to do because the learner is not there yet? And how do I make opportunities to include or involve that learner as much as possible? All right, so since we completely anticipated the slide, I'll just fill it in quickly. What we should have in teaching our adult learners in the clinical setting is have patient care at the center, with the attending close by. And then, of course, because we do have a professional clinical community of practice, we have our core here comprising the most senior trainees. And this, of course, is the emphasis here is on medicine. But then we've got the allied health professionals and the intern are part of this system, part of the orbit, basically, around this system, instead of just sort of flying through as a nice to look at sort of phenomenon. We still have our medical students more on the periphery. They are more junior learners, and so their capacity is limited with respect to the more senior trainees, but they have a place, again, in this orbit. And now what comprises the asteroid belt here are didactics and simulation. These are activities now that when you think about what are we trying to accomplish in the clinical environment in terms of promoting learners' capacity to help us get clinical service work done, We understand the role that didactics and simulation serve to help us achieve those goals. So we think strategically about what are the kinds of things that benefit from just-in-time didactics and simulation so that we can ultimately advance our clinical work. And this is where thinking about adult learning with respect to didactics and simulation is really potentially quite helpful. It helps those designers who are engaged in didactics and simulation, distance learning, other modes of learning that aren't in the workplace. It helps them, when you include them in the planning of that workplace learning, it helps them identify what are we designing this instruction for, and how do we design it so that it's serving those aims. Whereas if we were to just look conceptually at sort of just in case didactics and simulation and distance learning, we're not necessarily tied in to what can help us optimize the clinical workplace environment. So there's a lot of ways in which, if we plan ahead, if we think strategically about our workplace and we plan ahead, we can incorporate all the modes of learning productively into ultimately developing professionals who can engage in care. We have testing and documentation that fly through now as sort of interesting phenomena that we should attend to. And then Pluto, sadly, is not a planet in this system. But then the question is, what does this system assume about teaching? Any additional thoughts about this kind of system of teaching? That out.
I think still medical students are still too much distance with the patient care. It's like outside, yeah. I don't know, we can make some of the bridges, they can get near the patient care, and then sometimes they can be get outside, and sometimes no device to help the student experience the patient care. I think the clerkship is one of that, but I don't know if we can have more than that. Maybe we can think of the new ways of helping the medical students.
Yeah, I think certainly thinking about what do we want our clerkship students to be able to do, to know and do by the end of their, in our case, 4-week rotation. And how do we understand their goals for what that is and the curricular goals for what that is, and incorporate that into the way that we design our workplace curriculum. And one way in which I think it's done implicitly, which I think in many respects works very well, but is implicit, is that the students are often pairing with the residents, and they're closely involved with the residents who are closer to that core of providing patient care. And so I think an important message of this kind of clinical learning system is that we have to think about how we empower and develop our residents to serve effectively as teachers of adult learners. So this idea of learning the core tenets of adult learning theory, it applies not just to the attending, but to the residents as well. And how do we accomplish developing residents in this way, I think is really important, because I think that's where we'll accomplish what you're talking about. Anyone else?
I was thinking about the concept of responsive systems, where the system is not fixated in one particular setup, and it's able to be responsive to the need and the need of the moment, such that in the room with the patient in there in the moment, the system may consist of this setup where the patient is at the center, but that there is some movement back and forth between learning with the patient at the center, which should be most of the learning, while allowing some movement towards other setups as needed with other professionals moving into that center from time to time, and also continuing the learning process that's going on. Responding in that way to you know, whatever is driving the presence of the patient in the room or the ability of the patient. If there is an unusual disorder, for instance, where there is no patient presently that has it, a simulated patient may be the next best thing to still having learning happen with that simulated patient not taking over the patient, that center, and all the other learners circulating around it. And that way just responding to what our environment, what we have available.
That is a beautiful point and really, really important. And that we may have in our the critical importance of interprofessional collaboration in our work. We have, it may be the case that our allied health professionals are at the center of that system, or the simulated patient, if we lack the census to teach some of the important lessons that we want to teach, for example, or it's not safe to engage in the patient care as a junior learner. And I think that I agree completely that thinking about systems adaptively is really, really important. And the more that we employ systems thinking to as a lens for viewing what it is that we're doing in the workplace when we have learners in there, the more adaptive we can be, because we're going to be more attuned to the opportunities and the constraints, and we can think strategically and then in the moment about how we bring these things to play. And we have a wonderful advantage here with the MCLI. We've got a lot of opportunities to, just in time, pull some things into place. We have dedicated faculty who can help us with problem-based learning, and just-in-time kinds of classroom situations where we know that a certain kind of knowledge or form of knowledge is going to be really important to moving forward. We have the resources to do this. So then the question is, how do we imagine this? Like we can do this. So, okay, so that is mindful of the time since we got a late start here. Okay, so the implications then for clinical teaching is to consider teaching less, but making your work more educational. So that doesn't mean that teaching isn't going to happen, but does the attending have to be doing all the teaching? Does the resident have to do all the teaching? How do we think about making the work that we're all trying to do developmental for our diversity of learners? And planning and imagination are essential to this. It's interesting to me that West pointed this out in 1966. We have to think about our systems of learning if we're going to develop them effectively and then adapt them to circumstances in an agile way. And what this involves is co-constructing goals with learners and with other professionals, and identifying learning opportunities as a result of knowing what these goals are, of having built what these goals are. And then recognizing and engaging all of your teaching and learning resources. So this includes your educator peers, senior trainees. We talked a little bit about residents, our allied health professionals who have a lot to teach our learners, patients, simulation, our skills lab, textbooks, online resources, health technologies. It's very interesting, the implicit learning that our trainees are doing when they look at how their notes have changed in the EHR after someone more senior has taken a look at them. And if we can help our learners, for example, become more aware of the learning messages that are implicit in the use of health technologies, that's a learning resource, and it's not something that places more onus on the attending. So there's a lot of different and ways in which we can do this. The thing that I think is really nice about this is it takes some of the burden off the attending to always be on for doing this teaching. And it helps us think about how do we teach in a systems way. All right, but the common, okay, I hear it every time. It's like there's just really no time to do any of this. And I want to make the argument with the next slide that there are ways to do this so that while there might be some front end time, we can actually save a lot of time in the long run. So how might we do that? Well, I just want to introduce you to the concept of the educational alliance. And our psychiatry faculty here will be very comfortable and knowledgeable of the therapeutic alliance concept on which the educational alliance concept is built. And the key principles of the educational alliance is that both the faculty or the educators and the learners have a mutual understanding, a shared understanding of the purpose and the goals of the education they are collectively engaging in. And they have agreement on how to work towards those goals. And that agreement is something that's mutually created. So we have, on the one hand, we've got our curricular formats for helping to work towards these goals. But there's the reality that the student or the resident or other learner is a party to how education is implemented. So we have to account for how they learn and how we want them to learn and come to an agreement on how this is going to happen. And success then, this is the final principle, is that success is based on the trainees liking, trusting, and valuing of that educator and vice versa. So the key, the gatekeeping to involvement in clinical work and by the same token, engagement in clinical work is this relation that is built between the educator and the learner. So how does building these educational alliances save time? Well, for one, they can promote identification of opportunities to perform and be observed. So when you think about goals, this gives you now, instead of having just this undifferentiated, chaotic workplace environment that hopefully you can catch something that someone does that's good or maybe needs improvement, you actually now have a way of having targeted observation for what goes on. So targeted involvement and targeted observation. And this is really helpful with clerkship students in particular. When you think about, what are the goals that what are the realistic goals that we have for clerkship students versus our interns versus our second PGYs, PGY3s, and so forth. And this helps us focus and sensitize observation. If we're thinking critically about how and when do our learners perform, then this is what we observe instead of just trying to observe everything or observing nothing. And what this does is it accelerates giving feedback because you actually have something that you were watching performance for, and it gives you a chance to be concrete and reflective in real time because you actually had a target for what you were looking for. And it promotes a focus on action because you're thinking about the work environment as you are identifying opportunities to perform and opportunities to observe. You're, instead of focusing on, say, higher level sort of knowledge goals, for example, you're looking at how is this knowledge implemented in action, and how does that need to look in order to advance our care. It invites commentary on actions that are off course because now the behavior is about getting the clinical work done, and it feels less personal because there's already a scaffolding in place for what we're observing for and what we're being asked to give feedback on. So it kind of gives permission to do these observations and to have something to say about them. It enables personally meaningful feedback because both the educator and the learner have agreed on these goals. So we know that the feedback that we give to our learners on their actions is speaking to what they were intrinsically motivated to do in the first place. And that increases the likelihood that feedback is actually going to get used because it's meaningful, because the source is trusted, and because the change in what learners do is relevant. And that change enables them to work smarter, work better, so they don't have to rely as strongly on the attending to tell them whether they improve. They're actually getting that feedback from the environment because they're able to do more and do better. So these are just some ideas about how taking that front end time to do this planning and think about your workplace as a whole can actually make what we consider the teaching interactions in the workplace to be more productive with less time either taken to prepare or to deal with the fallout when it's not done well. So our take-home messages, and who wouldn't want to take home this adorable creature? I think it's a puppy. Not sure. Is that adult learning is all learning, and it requires and promotes agency, interaction, and involvement. Teaching clinical learners according to adult learning principles occurs via the workplace curriculum, which includes a strategic balance of different activities and sources of learning. It's not all on the attending. And finally, the front-end investment of time in educational alliances can accelerate the adult learning process. So these are our messages for today, and we have a little bit of time. I can't see. We have a few minutes where we can talk about or brainstorm ideas for how to put this kind of support to educational alliances in place. And I thank you for your time and your patience with our technical difficulties.
Yeah. We have just 1 minute. So,
For people who are willing to stay, I have a little extra time since we got started 10 minutes late. So, if you're willing to stick around, I'm happy to brainstorm and answer.
and also on the WebEx, you can definitely send us an email if you have any questions.
Mhm.
So thank you again for your time today, and thank you again for the session today.
I just want to say thank you. This also applies to my graduate students and the undergrads who work in the laboratory.
Yes, thank you. Do you have a second to share your thoughts on that?
Yes, certainly. Again, I would be similar to the attending, and they would be swirling around me in our little universe, our little cosmos of the laboratory. Certainly, we do a lot of activities, and there's a lot of active learning going on. And there's also lots of passive learning with talking to them. But I think in the laboratory, it's much more easy for me because it's a confined small area, right? It's not a huge hospital or a floor. So I think the principles are easier to apply.
Yeah.
We can continue our discussion here. So if somebody is have another thing to do. So just one quick comment. So you will get some evaluation form later. So please give us your insights to improve our session and give a constructive feedback to us. And our next workshop session is on March 21st at 12 p.m. Dr. Hyung Han will introduce curriculum development at the next time. Okay. Thank you very much, everyone. And if you want to discuss more, you can stay online. Discuss a little bit.
Of doing this presentation or a modified version of it for